Here today with Dr. Michael Arroyo. He's going to be here discussing status epilepticus in peds with us. Also, Greg Witcher is on with us, PGY2 from Texas Tech. We were hoping to discuss status epilepticus in children. These simple seizures we see often in the emergency department, both in kids and in adults. For most of us, most of the time, those are not a big deal. They're much more scary for the patient, I feel like, than for us. But when the seizures continue and don't stop, that's when, for us, I think they can become a little bit scary. We should probably have an approach before we come to that situation. And so that's kind of what we want to talk about today. So to start, Dr. Arroyo, do you mind introducing yourself briefly and telling us, where your training is and where you're from and that sort of thing?
So I'm Michael Arroyo. I am attending at El Paso Children's Hospital ER. Actually just started since September, at the beginning of this month. I just finished my fellowship in pediatric emergency medicine in Houston, Texas at Texas Children's Hospital. I did my pediatrics residency there as well. And I'm actually born and raised in El Paso, but I left after training. So I kind of came back home after all my training. So I'm excited to be back and to be here teaching all the younger doctors.
Welcome back. There are other attendings at El Paso Children's as well that are from El Paso. So it's good to have a core group of you guys that'll be around. It's really great. Yeah. Well, just to get into it then, how do we define status epilepticus?
Status epilepticus is a seizure lasting for more than 5 minutes. So any seizure activity, or it can also be multiple seizures, not necessarily 5 minutes of length, but multiple seizures where the kiddo doesn't come back to baseline in between.
That time frame is interesting from an emergency department standpoint of 5 minutes, because it seems like if somebody brought their kiddo in because they had a seizure, if you see them seize, we're probably going to be dealing with status, right? Because the seizure should have been gone by the time they arrive.
If the parent says they've been having a seizure since home, who knows how long it's been since they left home, I would probably start treating at that point.
And how about when you say back to baseline, does that mean 100% GCS 15 talking like we're talking, or, like a strong 14, or how would you describe that?
So not necessarily GCS 15 like we're talking, but kind of like waking up. It's also important to ask the parent, if they think their child is back to baseline, or if they think this is how their child usually acts when they're kind of coming out of the seizure. It's kind of those ones where it's like the first time seizure that the parent's freaking out, and anything not like us talking is not normal for them. But I think as long as they're waking up a little, you can easily arouse them. I think that's kind of coming back to baseline.
So with all things peds, ask the parents because they know their kids best. And if they're this is their normal postictal phase.
And like I said, I think that's easier when the kid has a history of seizures, so the parents kind of already know. So it's easy in that situation. But in the other situations, it's not as easy.
Before we really dive into status, then why do we need to know about this? What are kind of the dangers that we need to prevent?
So this is a very common neurologic emergency that you'll see, not just status, but seizures in general. Since I've started, I've seen several kids come in with seizures. I've actually had a couple in status epilepticus since starting. I've only had 5 shifts in the El Paso Children's ER, and I've seen a couple. And it's one of the most common, like I said, neurologic emergencies in pediatrics, and also can have an up to 8% mortality. Once you start passing, like I mentioned earlier, that 30-minute mark, that's when you're at risk for neuronal injury, especially if the kid doesn't have predisposing CP or some other disease. You can start losing your neurons at that point, and then obviously risk for losing your airway. So that's why it's important to kind of know an algorithm or know what to have in your back pocket in these types of patients.
That's so key. That's why we want to talk about this. This is not the type of thing that you want to look up on WikiEM,
right?
When it's happening. We need to have a plan right away. Awesome.
Yeah.
Are there different types of status that we need to worry about, or from the emergency department standpoint, status is status? What do you think?
So I think neurologists do have different types of status epilepticus that they like to kind of define. But I think honestly, in our world, the type of status doesn't really matter. I think what matters is having someone else, a surrogate, either one of the other residents and nurse, someone asking the family what, the situation that surrounded the seizure, because that'll drive your ancillary studies, your blood work and whatnot. But honestly, status is status. You're going to treat it the same either way.
One thing that I in the back of my mind I don't want to do is like have some kiddo with a simple febrile seizure or febrile seizure come in and just aggressively treat it, intubate them, do all these things, and it's just like a febrile seizure that probably would have broke on its own.
A simple febrile seizure wouldn't last probably more than 5 minutes. And honestly, have I treated a simple febrile seizure in the past? I mean, probably, but it's probably because the parents came in saying, "Oh, they're seizing at home and now they're seizing again." And usually they'll break with one dose of lorazepam. So it's not so much a huge deal for the simple febrile seizures because they're gonna break, and even if you give one dose of Ativan, they're still gonna come back to baseline. It's when they don't is when you start kind of thinking of other things.
And I suppose, it wouldn't make the definition of simple if they're still seizing over and over.
Right,
And that's
exactly.
not. So
if they're still seizing, it's now a complex febrile seizure.
right. So status is the status. Over 5 minutes, just go ahead and get at it. You provided this really great algorithm. It looks like it's all evidence-based from Texas Children's. So I think we could just get into it.
Okay.
Just the beginning, it says here, do we think this is a seizure? Big tonic-clonic seizures, easy to see.
Right.
Do you have any advice or any strange stories or any seizures that you've seen that, there was a seizure, but it didn't look like a big tonic-clonic type thing?
Yeah, I think so. A lot of the times looking at the kiddo's eyes, I obviously part of my primary survey all the time is getting pupil size. And I think that's something that residents tend to forget. But once you kind of open those eyes, then you can see they're either deviating or doing something funky. That can kind of clue you into a seizure. Lip smacking can be subtle. The kid won't be jerking or whatnot, but then you can see a little lip smacking, some tongue thrusting, or even kind of just finger twitching. If you look at the kiddo's fingers, you can see that, which is also be very subtle. Another thing is if you feel their tone and it's kind of hypertonic, then that can be another clue, especially if it's not, like I mentioned, a CP kid who would maybe be hypertonic at baseline. That's fine. But if it's another non-CP child, then it's probably not normal that they're so hypertonic if they are.
What's your preferred way to check a patient's tone?
I mean, I honestly go down to their legs and kind of flex right at the lower leg to see what their tone is, or even their arms. But I usually do go down to their legs. And then another thing that I also look for, especially in those kids that they're not doing a generalized tonic-clonic seizure and they look asleep, but sometimes looking at their heart rate can give you a clue too. If they're kind of having normal heart rate and suddenly they start jumping up to something that's not normal and you don't know what's causing it, I would consider a seizure at that point. Obviously, there's other things in the differential, like an arrhythmia, obviously, but that could be another subtle clue.
So if we see the kiddo and we decide, this kiddo seizing, their status has been over 5 minutes, what are our initial steps?
Obviously, ABCs, that's kind of the all-time everything in emergency medicine. Jaw thrusting the kiddo, I think that's always important as it pushes the tongue out of the way. Putting a non-rebreather on the kiddo, establishing your IV access as fast as possible, and then putting on the monitors. I think those are always the most important first steps. And then calling for your lorazepam, your Ativan. The other thing is having a Broslo, because obviously if you can't weigh the child, having a Broslo there, because I believe on the Broslo there's actually the dose of Ativan on there, perhaps. Yeah. If not, you'll have the weight, so you can calculate the dose of Ativan, which is 0.1 milligrams per kilo. So right. Having that initially, that way you have everyone that's in the room kind of helping you start doing something and things happen quick and simultaneously, rather than kind of step by step, right? Let's put this on, let's put that on. That way you have things kind of cooking.
I think the oxygen's a key point too, because they're at high risk for desatting, if their diaphragm's involved, I
mean, I've seen kids with seizures, and I'll walk in and the resident's in there, but hasn't realized that the child's desatting, and I'll quickly go to the head of the bed and just jaw thrust. Even if I don't have my non-rebreather, attached just yet, just that jaw thrust really opens up that airway.
What studies and labs should we get? We actually forgot to mention earlier, we should probably check a sugar right away.
Oh yeah, absolutely. A, B, C, D. D is for dextrose. Get a D stick, a POC glucose. I feel like depending on the situation surrounding the seizure will kind of guide your management. If it's an infant that may or may not have had a seizure, then I think for sure blood culture, CBC, a chemistry panel, UA, urine culture. Once you're kind of getting things situated, but the nurses are going to be placing an IV. They're going to ask you what you want. If you don't know anything, I would get a VBG, the one that has like the electrolytes also, because you can quickly identify also like a hypocalcemic seizure, which I've seen a few times in formula fed infants, especially the Hispanic babies for some reason where I train. It was always those babies that came in with seizures. You give Ativan, it doesn't work, and you get your VBG and they're hypocalcemic, and then giving them the calcium actually stops their seizure. So I think it's guided based on what you got in your brief history. If no history of fever, I would consider like a UDS too, a urine drug screen.
It's probably worth knowing what's the quickest lab you can get back in this case. Some places have ISTAT, some places have VBG, but probably not the time to send to lab if you have something quicker so you can correct the electrolytes.
Yeah. I think that whatever you can do, either point of care right there that the respiratory therapist can run or someone can run really quick to give you some other electrolytes, I think that's helpful too. And then also don't forget that you're probably going to have, if you get a VBG, it'll probably be a respiratory acidosis picture if they've been seizing for that long, but doesn't mean you have to quickly like intubate. I think look at your patient, make sure they're able to ventilate appropriately.
You obviously mentioned lorazepam. That's your number one choice then, it sounds like that's what you'd prefer?
Yeah, I usually use Ativan, which is lorazepam.
Right, lorazepam, and then IV.
Yeah, IV. Obviously, if you have IV, there's situations where you might not have an IV, and there's a couple options that you can use. Intranasal midazolam or Versed you can use, I think up to 0.2 milligrams per kilo with a max dose of 10 milligrams. And then you can also use rectal diazepam. I think it's 3 to 5 mixed per max 10 milligrams. And sometimes when you have a child that already has known epilepsy, they'll have their own rectal diazepam. So you can just borrow theirs if they have it with them, if they haven't already used it, and use that.
So IN midazolam, which is Versed, rectal diazepam, which is Valium, and if you have an IV, then go with Ativan, lorazepam.
Yeah.
We do IM for adults sometimes. Will you do that for kiddos as well or no?
I haven't. I mean, I guess that's something you can have in your back pocket. I haven't really used IM, mostly because that's usually slower. Really, the ones that I've used is either IV lorazepam or the diazepam, the rectal diazepam. And then I think EMS, if they can't get a line, I think they'll use like intranasal midazolam, I believe.
Have you ever had a circumstance where you had to like put in an IO or they get that bad that you couldn't get access?
I don't think I've ever had a situation with status that I've had to do an IO. Because usually either intranasal or rectal, you can get something in. If you can't get anything like quick, and let's say the kid's like crumping, they're desatting, they're becoming bradycardic, then you're kind of getting near some bad stuff there, ready to arrest. Then I think an IO would be perfectly fine.
One thing I was noticing is the dose 0.1 mg per kg. You can max it out at 4 milligrams. So I see often in the adult ED, somebody's having a seizure and they ask for 2 milligrams of Ativan IV, which, seems like nothing. If you have a kiddo that's only 20 kgs, that's already 2, and that's a little guy, that's like a 6-year-old or something.
So it's max 4 milligrams. Honestly, I try to do it. Also, I use the 2 because 4 milligrams kind of scares me a little too in these little kids. So I'll round down. If it's like 3 point something, I'll round down to 2. I think it's also easier for the nurses to drop rather than like 3.25 or 3, some like weird number. So I will either like use 2 for like those younger ones, but for the older ones, I will use 4.
Because breaking the seizure is probably more important.
Yeah.
Worst case scenario, you protect the airway for a minute.
Right. Exactly.
How long should we wait to redose?
Usually 5 minutes. I usually will wait like anywhere between like 5 to 10-ish minutes because sometimes the seizure will stop in that you won't see a full general tonic-clonic, but then that's when you start looking for like your subtle signs, your lip smacking, your tongue thrusting, your like finger twitching. And if I still see that, and usually it'll take me some time to kind of assess the patient real quick. And by that time, it's been, like 5 to 7 minutes, and then I'll give the second dose.
And when you do your second dose, do you do the exact same thing that you did in the first dose, or do you try to change it up?
No, I do the exact same dose that I used on the first one.
Now we give 2 doses of benzos, and hopefully we've done the appropriate weight-based. Now is probably the time where, they've been seizing in front of us for 10 minutes, probably longer with EMS. probably the time where we need to start making some real decisions here. So kind of what's the next step?
At this point, I have levetiracetam, which is Keppra, in my back pocket, and also fosphenytoin. So Keppra, I'll usually use 30 milligrams per kilo. At Texas Children's, sometimes we would go up to 60 milligrams per kilo. And I think it's max 4,500 milligrams. And then fosphenytoin, I think it's 30 phenytoin equivalents per kilo with a max of 1,500. So I'll have those two. And honestly, at my other institution, it was harder to get fosphenyl. So I would order it, but I would also order Keppra at the same time. And I would always get Keppra first. So I would give the Keppra at that time. And then if the kid is still seizing, let's say 5 minutes later, then I'll probably end up giving fosphenyl. But by the time getting to like that point where it's been like 10, 15 minutes of the kid was still seizing at home, now we're nearing towards that 30-minute mark where bad things can happen. So I'm also, considering an airway at this point. Maybe not, pulling the trigger, but I'm having the RT start, preparing, having things ready so that if I do decide, it'll be easier.
One point that you just made there that to really emphasize is the dosing for Keppra. It's larger than I feel like we often give. 30 mgs per kg, and you can, redose. You can do that twice. 60 mgs per kg is a lot. A kiddo that weighs 50 kgs is going to get a lot of medicine. A lot of like in the adult literature and blogs and kind of the foam world right now, I feel like there's a lot of talk about if you're getting to that second line medication, it's like innovation time. Like, don't give the second line medication a chance to work, because some studies show that they may not actually work that well. What do you think about that?
You should be seriously considering an artificial airway at that point. Like I said, maybe not pull the trigger or just wait for like the, your second line to be given, to give it a, some time, like 5 minutes max, 5 to 10 minutes to work while you're getting things ready. Because after that, then, if that's not working, then I think at that point for sure, you have to secure an airway. As long as you have like your bag valve mask hooked up, you can always, if the kid becomes apneic for whatever reasons, the benzos start catching up, then you can always, bag the kid until you're ready to intubate.
So this is very stepwise. So far, we've done the Ativan, 5 minutes, Ativan, 5 minutes, Keppra or fosphenyl, 5 minutes, hopefully. So 30 minutes is like the definition, but ideally this would even be before then. It kind of sounds like that we would make a move. Let's say we've done these medications and they're still seizing. How do we approach this airway?
Yeah, so I think now getting your airway material ready, your drugs, obviously. So what I usually use, it's status. I do fentanyl Versed because we're already giving benzos, and the next step after that is putting them like on a Versed / midazolam drip, giving them kind of like the loading dose of the Versed. I think it's 0.2 milligrams per kilo for your induction medicine. I think is totally appropriate. So I do fentanyl Versed, and I do rocuronium too. And then having your ET tube set up, having another type of airway like an LMA just in case is also ideal too.
I feel like I've seen propofol used quite a bit. Do you ever use that, or what do you think about that?
I don't think I've ever used propofol. It might be just because of where I trained. We never, not even for like sedations, we use propofol. I was trained mostly just on fentanyl Versed, rock, ketamine, rock, etomidate, rock. So rock is what I've been trained on and what I'm more comfortable with.
That's interesting, yeah, because it's like if you already gave a couple doses of benzos and they didn't work, it's like more benzos. One question I did have is rocuronium probably lasts, 45 minutes or so. In an adult, I'd say probably similar in kids.
Yeah, maybe. I think when I was looking up for rock, it was like 90 to 120 minutes up to.
Right. So that's a long time. So one concern, if we're at a children's hospital and we can get them to a neurologist and, get an EEG going, we can see if they're still seizing. What do you think about, like, if we're at a community hospital and we're going to put this person on an ambulance and send them to the children's hospital, they could very well be paralyzed and seizing and we wouldn't know it. Can you think, are there scenarios where you'd say maybe more like a shorter acting paralytic would be reasonable? Or do you think just going with rock is the best choice?
I mean, I guess it also depends on how far. Are you like in a rural hospital where the children's hospital is 2 hours away, or are you going to fly them? It's going to take like 45 minutes to an hour. I think by the time they get to your accepting facility, by the time they get situated in the ICU or wherever they're going, it's going to be around like an hour and a half to two probably, where the rock will probably already be wearing off. And then they can put the EEG and they're going to catch a seizure at some point anyway. So I think doing what's safest for the patient, because you would hate for them to start moving en route and then they like pull the tube or something like that, then it's not ideal.
Right. So so keeping them paralyzed just for transport.
Yeah,
that's pretty good. It's just you are masking though a seizure, so you don't know if if you have enough of the Versed going or enough of whatever you're using.
Right. Yeah.
Mm-hmm. So just to confirm, you're inducing with Versed at 0.2 milligrams per kilo, fentanyl at, I assume, 1 per kilo, and then you're also doing a post-intubation drip of both of the same thing.
Yeah, I
with
will.
The rocuronium during the RSI too.
Yeah, you can do a Versed drip thereafter. Yeah.
Mm-hmm.
I mean, and you can do, the ICU will do both fentanyl and Versed, but I usually will just choose one from the ER only if the child's going to be in the ER for a while. Because obviously if the bed's ready, then you don't really have to order your drip at that point, but having some like PRN doses of Versed and or fentanyl, so you can give right before the kid's transferred up to the ICU. Because they're going to put the child on a Versed drip upstairs. So if they are going to be in your ER for a bit, which hopefully they wouldn't, a Versed drip would be something that I would start.
Have you ever had any experience with using ketamine for any of these things? Because theoretically, it lowers seizure threshold.
I haven't. You can use ketamine also for induction too, especially like if your kid is still seizing right before you're going to intubate, then obviously that's not ideal. So ketamine is another one that you can definitely consider. I've never done like a ketamine drip for that, mostly because they're not in my ER by the time that happens. But you can definitely consider ketamine too.
So at this point, we've got them intubated and stuff. It actually says you can consider phenobarb at 20 mg per kg. Have you had any experience with that? And what do you think about phenobarb at all?
I think when I'm considering phenobarb, that's after obviously the phosphonitoin hasn't been working. I intubate them, and then I'll talk to the neurologist, and I'll tell them like, hey, this is what's been going on. This is what happened. I intubated. I mean, maybe they still are having some like seizure movement. Maybe they're still having like the finger jerking or whatnot, but less likely because they're paralyzed. I don't know if I've ever given phenobarb in the ER because, like I said, by that time, they're probably already up in the ICU, hooked on to EEG that's hopefully catching seizure activity.
If your institution had it, do you think it'd be reasonable to give as like a second line? Or
I don't think I would give it instead, just because, if you're going to use phenobarb, you probably should be intubating, because that's probably going to cause you some respiratory depression. So if you use the Keppra phospheny first, you're giving a second line, and then you're kind of hoping that it stops. Because the good thing with Keppra is that it's not going to cause respiratory depression, and then phospheny won't really cause too much respiratory depression either. So you're giving the kid a little bit of a shot to kind of stop. So I feel like phenobarb is very, I don't know. It's my third line. I'll have it in my back pocket if the kid's still in the ER, still seizing after they're already intubated.
A lot of side effects, cardiopulmonary side effects. Yeah.
I have seen, I've only seen it used honestly, like in like little babies, but the oral version that's how they control their seizures. But I haven't seen it used like giving like a push IV dose for seizures.
Right. And the only reason I ask is just because it's like, like the blogosphere, like phenobarb is like this new thing that like people, it's not new, it's old, but people are like, all this evidence that it's good. But as with like all of these critical situations, I think that's why it's important to talk about these things that, I don't want to like base my treatment on some blog. If you've been doing this, it works. It's like, let's do what we know works,
Right. And then honestly, maybe there's like newer studies coming out in the adult literature about phenobarb, but I feel like just like any type of condition, pediatric studies are usually a little behind the curve compared to like the adults. So maybe like in 5 years, we'll be having a different conversation when we'll be giving phenobarb instead of like Keppra phospheny.
And you kind of mentioned earlier, then one pitfall that you see is that we may ignore the pulse ox, as we're focusing on a seizure, we don't actually think about the side effects such as, desaturations. What are other pitfalls that you've seen with residents?
So I think, yeah, I think the biggest ones is, recognizing the seizure, not recognizing that they're desatting. I think just airway things that jaw thrust. And the other thing is if they're like, after they're, let's say you stop the seizure, they're post-ictal, especially those like larger kids, the adolescents, they are going to be obstructing especially if they're on the larger side. So having like a nasal trumpet to open their airway, and that also stimulate them so they can, start waking up too. I think also having like a toxic ingestion on the differential is pretty high. That's something that people tend to forget. I remember a patient I had in fellowship where I was managing the patient, and the kiddo just kept having like these like staring spells. They would just stare off to one end, and the story was like completely fine until like an hour before, and they started not acting normal. They weren't having general tonic seizures, but the kid would just like intermittently stare off, be speaking like super slow. This is like a 3 to 4 year old, but then was having like several apneic pauses. And I had already done obviously my altered mental status, but then I got a UDS and it was THC positive. And this is after I had intubated already too. So it helps in that sense. I mean, obviously you're not going to do anything about it like medically right there, but it kind of gives you like an answer. So having talks high on the differential, asking what medicines are at home, not just prescribed medicines, over the counter like Benadryl. If the kid took a whole bunch of Benadryl, can be seizing, but knowing what medicines the family has at home.
That's really good. I think tox is an easy thing to not keep on your high enough on your differential. It should always be in the back of our minds. You mentioned the formula-fed hypocalcemia. You mentioned THC, and what are the other toxidromes that you are keeping at the forefront of your mind with these seizing patients?
I think the big one for me is the Benadryl. I think that's the biggest one. Especially the older kids can have like polypharmacy, and that in and of itself can cause a whole bunch of weird things. The Benadryl is a big one. That's the one that kind of pops into my mind right away that I'm thinking of. I guess also some like stimulant, if older adolescent, that cocaine and whatnot, or other types of stimulants can also cause some seizures.
But I think if, as far as an approach, if somebody comes in, you have an idea about why they're seizing and it's some sort of toxidrome, then it's like attack that. Like I understand that, but if they're coming in and it's kind of undifferentiated, right, just a seizure, like you're going to treat the status through the algorithm.
Your workup's going to be, you're going to cast a big net, sometimes even getting like a head CT, if you think there's a bleed. I've definitely seen ruptured AV malformations that come in seizing, and they won't stop. And I'll have to intubate them, and then we'll take them to the scanner and there's a huge bleed. So trauma, anything, really getting not necessarily a thorough history, but kind of hitting all those high points.
And then the electrolytes ones, I think that's super important too, because I've definitely seen that in status before, and they're hyponatremic or something that's correctable.
Right, exactly.
So try to get the quick.
Hypocalcemia in those infants. Yeah, those are important. Especially the hyponatremia, what comes to mind is, asking the parent how they're making the formula, because maybe they're putting too much water in the formula, which can definitely cause hyponatremia in a baby.
All right, well, that's been pretty good. I think we have like a pretty good approach. This algorithm's pretty clean. It's the type of thing that we should probably really know well before it happens. Do you have any final recommendations or suggestions?
And I know initially you mentioned, this is not the time where you should be pulling up WikiEM, but which probably isn't. But honestly, like you're in a stressful situation. The ER, especially in these situations, is very stressful. You have, it could be pretty chaotic in the room. You probably have a parent behind you yelling. So it's okay to take out, your resources real quick. That way, I always have my laminated sheet that I always carry in my pocket in addition to my PALS card, and I'm always taking it out, even for like checking like a GCS. Even though I can probably know what a GCS is when I'm like not stressed out, but like if you're in a stressful situation, it's definitely okay to pull out your resources. And the Broslow card has a lot of good. I think it has your ET tube sizes, your medication doses. So I think it's totally appropriate to use whatever resources you have there.
Yeah, absolutely. And you're not the first, emergency person that has told us this, that, it's okay to take out your cars and your algorithms and walk through them, because now's not the time to be concentrating and doing math in your head, that sort of thing.
Exactly. Yeah, exactly. And, talking, like saying things out loud when you're at the foot of the bed, you're the team leader. It's okay to, think out loud. Not only that, but after each step, it's good to kind of summarize what's been going on. So we have this 15-month-old patient that's been now seizing for this amount of time. We've given this amount of medication. Our next steps is this, and then we should anticipate an airway. That way it lets everyone in the room know what you're thinking, and people can speak up if they, they have some sort of comment or concern, and the room knows what your next steps are. That way they don't have to be guessing what you're thinking.
Yeah. And that's great advice just for all critical patients.
For all, yeah.
So, yeah. Well, I really appreciate this. Greg, do you have any final questions or anything?
No, I think that was a perfect note to close on. This has been really helpful.
Yeah.
We look forward to working with you in ED.
Thank you, guys.
Thanks a lot. So first we started with definitions of status. Status is a seizure lasting longer than 5 minutes or multiple seizures without a return to baseline. For our so-called chronic patients, you may need to ask the parent if the patient has returned to baseline, because baseline is, of course, relative. Why do we care about status? Status is common. Status has actually a relatively high mortality if it's not managed appropriately. So moving on to the approach, Dr. Arroyo emphasizes that you should check pupil exam. You should check those other physical exam findings that can be subtle, such as lip smacking, finger twitching, or overall tone. Onto treatment, especially for interns, this is super important. These things need to be reflexive because these are true emergencies. So in terms of the ABCs, get control of the airway with a jaw thrust, reach for that non-rebreather max to optimize oxygenation right away. And then if you have a larger kid, they might benefit from an airway adjunct like a nasal trumpet. If the patient doesn't have IV access, that's certainly the priority. When you're calling for meds, don't forget the Broslow tape. That's going to give you the right dose. A normal dose for an adult can be a whopping dose for a kid. So diving deeper onto medications, lorazepam is Dr. Arroyo's #1 choice, as for many others the same. He uses 0.1 milligram per kilo. If you don't have IV access, you can fall back onto intranasal midazolam, and then if you are in the pre-hospital setting or are in a pinch, you can also use rectal diazepam if need be. So if you're facing the situation of redosing, don't be afraid to trend the physical exam findings that we mentioned earlier, like jerking or tone. And then the second dose can be the same as your first. After that, we're switching to agents like Keppra or phosphenitoin. That was what Dr. Rowe recommended based on the Texas Children's Hospital protocol. And you should start thinking about artificial airways at that time. So getting more into artificial airways on the topic of RSI, Dr. Arroyo uses fentanyl and midazolam for induction, which is a little bit different than what we usually use on the adult side. So those are things to get familiar with as much as you can. He uses trusty old rocuronium for paralysis. When asked about phenobarbital, he said he usually leaves that up to the inpatient team and his neurologists, and not something that he's using on a regular basis. So once the patient is stabilized, then you're thinking about your workup. The lab deed order would be the same things, apart from a VBG with lights, which is something that can be useful in distinguishing the etiology of status. Dr. Arroyo had told us a case about a patient with profound hypocalcemia from formula feeding that developed status epilepticus. So then Benadryl was another possible toxic cause of a status epilepticus that Dr. Arroyo mentioned and highlighted, something to be aware of. As always, I asked him about pitfalls for resident management. He said the first thing is always to try to recognize status epilepticus. That's something he's seen residents miss in the past. And then try to optimize oxygenation by trending that pulse ox and using the jaw thrust to manipulate the airway to get good flow. Last and maybe most importantly, Dr. Arroyo admitted he's not afraid of pulling out pocket resources while he's taking care of a patient. So don't be embarrassed to do that if the pros like him are doing it too. All right, so we hope you found this helpful. That's all for now.